Clemens Wendtner from Munich and from the CLL study group in Cologne, who's going to talk about the German guidelines and why everyone should use bendamustine. Clemens.
So, thank you very much, John. I haven't been to Lugano as long as John. At least I haven't been to the sun as long as John. So, okay, thanks for.
I was in the session all afternoon. It's a sweat. Yeah.
Okay, just kidding. Thanks. Thanks for the invitation. So my task is to give a little bit the German perspective on how we use CLL treatments in Germany and how we try to put this in words. So before talking, here are my potential conflicts of interest, my disclosures. You see, hopefully well balanced, because we have a lot of connections to many companies, so the money gets diluted after a while. So now we talk about first the classic road of chemotherapy. So John has already told you that there are certain standards. One clear standard is the FCR for the very fit ones. There is another standard, I will tell you later, is BR, and there is also some use of chloramazole still. But we do this now slide by slide. The first thing is FCR seems to be a very potent treatment for very fit patients, with especially with a mutated IGHV. So this is the overall survival curve we have plotted based on the CLL8 data. Kirsten Fischer has presented these data, and the data are submitted. You see that actually the overall survival curve is above 80% after a follow-up time of roughly 6 years. We have very similar curves from the MD Anderson Cancer Center in Houston. Now, but there is a backside of FCR. You know about this toxicity. We do see neutropenia in roughly 33% of patients when we just count it directly after therapy. We have in 25% grade 3 and 4 infections. But in addition, you see in this table, there are also cases with so-called SPMs, so secondary primary malignancies, and this accounts up to 15% of patients. We do see Richter's transformation in 5%. We do see solid tumors in 7%. And this table goes on with neoplasias, especially MDS, secondary leukemia in 3%. Some skin cancers. I'm not looking to John now. This is more mesothelioma. And we do see prolonged neutropenia. So after 1 year, we still see in 4% of patients prolonged neutropenia. So this is the backside of FCR. These data actually have been collected by Kirsten Fischer and are submitted. Now, Barbara Eichers presented at ASH a few months ago the face-to-face comparison between sorry, there was just one too quick, the FCR and the BR, so the bendamustine rituximab. So what everybody had a little bit a gut feeling of was that we do see more neutropenia with FCR. Was a little bit striking that the difference in severe infections between BR and FCR is quite high. So this was one important note from this trial. But on the other hand, efficacy-wise, FCR is now on these updates Barbara showed the clear winner compared to BR. So the median PFS is higher for FCR compared to BR. This is the trial CL10. I just stress it again for fit patients. And this trial excluded the 17P population. On the other hand, when we do something we should not do is to look at different age groups. And we just did this. This was not pre-planned, this age subgroup analysis. And you see in the patients above the age of 65, you're not 65.
No, but I have a question on this slide, if I may.
Okay.
While it's up there. So it looks as if your older patients are doing better than your younger patients on both arms on this slide.
Yeah, but I wouldn't stress this too much.
Oh, I see. We're only allowed to stress the bits you want to stress on this slide. Is that right? Okay.
So my point is just that the BR is as good as the FCR for the elderly ones, efficacy-wise, but toxicity-wise, it's clear-cut. So the FCR is much more toxic in the older ones compared to the BR. And this is not something 2–3%, this is a doubling of severe toxicity. We're talking only about grade 3 and 4 toxicity. So you can now discuss in a very academic way that this was not a pre-planned analysis, but in the end we have to treat the patients. And I mean, from the old Greeks, we learn a lot of the Greeks nowadays, but also from the ancient days we learned a lot, and you see that we always are between two extremes. It's high efficacy, we can call this killer, and there is high toxicity, this is corruptus. And this is the sailing boat in between, and we have to find our way. And being also a clinician, I have to choose. And the choice I did from the CL10 trial is to say, okay, let's give the BR to the elderly ones. We might lose a little bit efficacy, but we don't put the patients on a real harm. On the other hand, the very fit ones, they should receive still their FCR. And this was a consensus within the German-speaking countries, so it's not only Germany, it's also Austria and Switzerland. This is the so-called Oncopedia guideline. You see the internet link, the www.oncopediaguidelines.info. You can track this down. This was the story for the fit ones. Now, also in this Oncopedia guidelines is a very update on the incidences of CLL in Germany, based on the data on 2011. It's now published in 2014, and you see a picture not surprising us that we do have a lot of elderly patients above the age of 70, 75 again. So here we also have to discuss other options, besides FCR especially. So chloramycin is still a backbone, and Valentin Goede published these data together with the German CLL study group, showing that the addition of GO101 to chloramycin is superior to chloramycin if we look at overall survival. So this is a real overall survival benefit if you add an anti-CD20, a modern anti-CD20. Now, PFS-wise, there is also a conclusion from this trial that the GO101 is the better anti-CD20 compared to the rituximab. But you see, it's only PFS. So far, it's not proven with overall survival. Now, to be balanced, because this is a European audience, so also the British guys have published the Complement 1 trial. So Pete Hillman published this recently in May. This is the phase 3 comparing the chloramycin plus ofatumumab versus the chloramycin monotherapy. And a very similar picture, you see that there's a superiority of the chloramycin plus anti-CD20 arm, in this case ofatumumab, compared to chloramycin monotherapy. This is again only PFS. Now, what is the treatment reality in Germany? It's different. If you see here the chloramycin, it's hardly fine to be found here from the front desk. You see. We do use, obviously, chloramycin in a very low frequency, at least based on these tumor registry that has been presented by Wolfgang Knauf, so thanks to Wolfgang. And you do see that BR has a frequency of use above 60%. And this is not declining. Now, again, we had to do a consensus because the German guidelines are based on also clinical practice. And you now see that this red box includes all the things I just mentioned. So BR is one option for the unfit, for the slow-go patients without a high-risk aberration. Chloramycin rituximab, you could use, if you decide for chloramycin, I would prefer the chloramycin obinutuzumab or GO101. In the UK, you would probably see more chloramycin ofatumumab. It's not widely used in Germany, the ofatumumab in this context, and I would not advertise too much for the Benda ofatumumab. It's based on 44 patients, so I'm not really convinced about the last one here. So, nevertheless, we mentioned a lot of Benda Rituxi in this case, so we published these two phase 2 data some years ago, but we have to admit, for 17p deleted patients, BR is not the choice. You do see it doesn't help, so there we have to really think about the new drugs. And John Greben introduced them already, so ibrutinib, the BTK inhibitor, you will hear more about this later on, Idela, the PI3 kinase inhibitor, and the BCL2 inhibitor, especially ABT199 or venetoclax, where you also have many abstracts at this meeting. Now, it looks like that with these new drugs, we are entering the fountain of youth. So there is eternal life, and we can add one drug to the other one, but that's more a dream, but at least we have options for our patients. So these are just some snapshots of data that were presented at ASCO 1 year ago. They are meanwhile published. These are the PFS curves for ibrutinib. You see treatment-naive patients are doing very well. The PFS above 90%, and the orange line is the refractory, relapse refractory cases. They are still doing very, very nicely. We do also see responses, nice responses and nice survival in the 17p group, but you do see it's not forever. It's not eternity. The same is for idelalisib, in this case plus rituximab. These are the official curves. You also see they were presented at ASH half a year ago. So the upper curve is Idela plus rituximab. The lower one is just the rituximab, so a clear benefit for Idela. This is also true for the high-risk group, deletion 17p. So this has also been introduced in the German guidelines. You see the yellow boxes now. This is frontline, fit ones with a high-risk aberration. This is licensed in Germany and it's also reimbursed, so we can use it. Either ibrutinib or Idela plus rituximab. The campus, the alemtuzumab is in bracket. I wouldn't use it anymore. The same is true for the less fit ones. You have the same option. So in this case, there is no discrimination between fitness if you use the ibrutinib or Idela in this high-risk group. Now, the Oncopedia guidelines also had to say something about the relapse refractory cases, and you see many boxes, a lot of these new drugs in these boxes everywhere. There is one exception. This is the allogeneic transplantation that should be considered for fit patients, either after relapse, after these new drugs, or even after 1 or 2 years when they are really young and you want to offer some curative approach, because we do not know at this point whether these new drugs are curative. So this is the EBMT consensus that has been published by Peter Dreger and colleagues last year. You do see that even in responsive patients with novel agents, when they have a high-risk disease, this means a relapse refractory plus a 17p or TP53 mutation especially, you should discuss with the patient the allogeneic transplantation. For non-responders, if they are still fit, I think that's clear-cut that you should send them to the allogeneic transplantation. Now a little bit more about Greece and the Greeks, the wisdom from Greece. You see, this reminds me a little bit from about the modern legend of Icarus. So Icarus was the son of Daedalus, and the father told the son not to fly too high because the wings will melt down if he flies very close to the sun. So we have to see certain rules also with these new drugs. And you know how this ended up? This is a picture from the 16th century from Peter Bruegel, and the front line might see the fall of Icarus. This is the yellow arrow, so you might see it also in the back row. So he just got in the sea and died, and the father made it to Sicily, actually. Now, what are the side effects? So BTK side effect number 1 is bleeding. Happens in 44%. In 40% is only grade 1. So it's not always as much as you do see here. This is a picture of a patient of Simon Rule. This is a patient of mine. He was really complaining of arthralgias. You do see a lot of white things here in this ankle. So this is actually the patient couldn't walk after a while, and we had to give him some non-steroids in order to get rid of these complaints. But you have to talk about this with your patient. So PI3 kinase inhibitors, on the other hand, colitis. Severe colitis can happen up to 16%, usually a late onset thing after 6 or 7 months. Pneumonitis can happen earlier. This can happen after 1 or 2 months even. And the question is now, with these nice drugs with also some side effects, what does the crystal ball tell us? I would say chemo plus the novel drugs, it's not a contradiction. So I think as in life, sometimes opposites attract. And there were first data actually by Jennifer Brown. She combined the benda-rituximab plus the ibrutinib with high over-response rates, with high CR rates. But this was just a phase 1/2 trial. Now at ASCO and last week in Vienna, we have seen the data from Helios. So this is a phase 3 comparison of ibrutinib plus benda-rituximab versus just benda-rituximab alone. And just to make a long story short, these are the survival plots. In red, you see superiority of the triple combination, including a BR backbone. With respect to overall survival, there is still no difference at this point of time. So this was the reason also for us to say, okay, we might have the chance with these new drugs, when we combine them with a chemo backbone, a chemoimmuno backbone, this is not too toxic, that we might even achieve complete remissions, that we might even achieve minimal residual disease-free status in the patient. And so we introduced in our new trials this MRD-tailored maintenance therapy. So we stop when we have an MRD-negative disease status after 3 months. And you see the combinations, big bag, BCG, and bio. So you see a lot of bendamustine in the beginning, but this is only 0 to 2 cycles. Then the patient receives a combination of an anti-CD20 plus a kinase inhibitor, so either ibrutinib or Idela, or a BCL2 inhibitor like ABT, and this is followed by a maintenance period. You would see, or have seen this afternoon, sorry, Paula Kramer has presented the first data of the big trial and also mentioned the back trial that's also open right now in Germany. So coming to an end, I would like to summarize. I hope I could convince you that frontline treatment for patients with a standard risk of CLL should include chemo backbone. This should be chosen fitness adapted. So it's either fludarabine, if you're thinking about the FCR, it's a benda, if you're thinking of the BR, or chlorambucil, if you're thinking about the anti-CD20. So this should be added with an anti-CD20, so rituximab, GA101, or ofatumumab. So these novel agents, we mentioned the ibrutinib and the Idela, they are highly efficient. They altogether have limited toxicity, so I've shown you very dramatic pictures, but just to have a take-home message for you, to have some awareness there. License in most countries worldwide in relapse refractory cases, but in Germany, because I have to talk about the German practice, we also can use them for frontline CLL patients with ultra-high risk, meaning 17p deletion or TP53 mutation. So we still have to define the role of these kinase inhibitors in the context of allogeneic transplantation. You have seen the perspective. Right now in Germany, we have clinical trials ongoing, combining these new agents with antibodies, with immunochemotherapy, and we also try to include a strategy to discontinuate these new drugs, so it's not forever, when we do see patients with an MRD-negative disease. So having said this, I've showed you the simple road in the beginning for chemotherapy. I think this is a more beautiful road we now see. It's, this road number 1 in California. So it's a very nice perspective, almost as nice as here in Lugano. So there are a lot of promises. You see the bridge. There might be also some challenges in the future we do not see right now. And you see the mountain, the hill in the back, there might be also some surprises behind the mountain. So having said this, I would like to thank you and happy for your questions.